Good afternoon. My name is Adhd Griffin, and I'd like to welcome you to today's webinar, Attention Deficit Hyperactivity Disorder in Preschool Children. This webinar is a part of the monthly Ask the Expert series sponsored by the National Resource Center on ADHD. The National Resource Center, or NRC, is a partnership between CHAD and the Centers for Disease Control and Prevention. It is a privilege to welcome today's expert, Dr. E. Mark Mahone, Ph.D. Dr. Mahone is Director of the Department of Neuropsychology at the Kennedy Krieger Institute in Baltimore, Maryland, and an Associate Professor of Psychiatry and Behavioral Sciences at the Johns Hopkins School of Medicine. He is the Principal Investigator of the NIH study, Development of ADHD in Preschool Children, Neuroimaging, and Behavioral Correlates. Dr. Mahone is also President-elect of the American Academy of Clinical Neuropsychology and an editorial board member of numerous professional journals. His research focuses on brain behavior, relationships in children with disorders such as ADHD, learning disabilities, and sleep disorders. We would also like to extend a special thanks to the Kennedy Krieger Institute in Baltimore for making it possible for Dr. Mahone to join us today. Kennedy Krieger Institute is an internationally recognized institution dedicated to improving the lives of individuals with developmental disorders of the brain, spinal cord, and musculoskeletal system. In just a moment, Dr. Mahone will give a brief overview of ADHD in preschool children, followed by a 45-minute question and answer session with you, the audience. Written questions can be submitted in the questions box on your GoToWebinar toolbar as indicated by the red arrow shown in this slide. We will not be accepting spoken questions today, by telephone or through your computer's microphone. If you are joining us by telephone, you will still be able to hear all questions and answers. Please be aware that audience participants have been muted, so the only voices you will hear are those of the moderator and our expert. All questions are moderated, and we will try to get to as many as possible during the 45-minute question and answer portion of this webinar. Finally, the information provided during this webinar is for educational purposes only and is not intended to be medical advice, diagnosis, or treatment. You can begin submitting questions if you have them right now at any time. If you experience technical problems or miss any portion of the webinar, you can contact the National Resource Center at the number on your screen. And also note that the recording of this webinar will be available on the NRC and CHAD websites within a few days after the webinar. Again, we are very pleased to welcome to today's expert, Dr. E. Mark Mahone. Dr. Mahone, if you'd like to begin.
Thank you, and thank you for allowing me to make this presentation today. Next slide, please. So, I want to give a little background on the current thinking about childhood ADHD and how it may relate to our thinking about understanding this disorder in younger children, especially preschool children. We do think about ADHD as a major public health problem right now, and the most recent estimates from the CDC are that over 5 million U.S. children have this disorder, and that number seems to be going up. In fact, the CDC recently published estimates that approximately 9% of children in the age range of 5 to 17 have actually been formally diagnosed with ADHD. Now, this is a concern because there is an annual cost associated with the care and treatment of ADHD, not just in the medical treatment and the educational care, but also in the medical care that's associated with the coexisting conditions and the fact that individuals with ADHD have a higher incidence of going to the hospital and receiving emergency care, as well as having a higher incidence of being incarcerated. Next slide, please. So here are the CDC numbers, and what's interesting about this is that this publication just came out in 2011, and a couple of years ago, when we used to look at the rates of these numbers, even up until the last iteration, which was up until about 2006, it looked like the numbers were not increasing all that dramatically. But if you'll notice on the slide, in the last 3 to 4 years, it appears that the rate of ADHD has actually jumped up a bit over the last couple of years, and that's both in boys and in girls. What we have found and what the CDC reported is that there does seem to be an increased rate among minority populations, especially Hispanic populations, over the last 3 to 4 years that may contribute to some of the increase. We also think that there's increased awareness in reporting ADHD, and that there is a higher rate of thinking about the disorder in younger children these days. Next. When we think about ADHD, though, I think it's really critical to understand that, for the most part, children with ADHD do not have this disorder in isolation. Most children with ADHD have something else, and that something else can really contribute to the problems that are seen, can make it more difficult to make a diagnosis, and it can also complicate the understanding of the function that one sees as well. Some of the most common coexisting conditions with ADHD are developmental learning disabilities, conduct and behavior problems like conduct disorder or oppositional defiant disorder, anxiety and depression. I think it's really important to note that the high rate of learning disorders and learning disabilities among children with ADHD, that the estimates of reading disorder, for example, dyslexia, is that about 35 to 40% of children with ADHD have coexisting dyslexia. Conversely, about 35 to 40% of children with dyslexia have coexisting ADHD. So these are two very common disorders of childhood that go together. So I think in thinking about treating ADHD, it's very, very important to think about the other conditions that go with it, because if you just treat the ADHD alone, often you're going to be missing part of the problem and won't get as good of outcome. Next. So there's concerns. What you see with the the rising numbers of ADHD. People have started to talk about, well, maybe there's there's too much diagnosis, or there's an epidemic, and there certainly have been questions about epidemics in other childhood psychiatric conditions, especially things like autism, and we know that the numbers for autism have really increased over the last 10 years. As at the rate of ADHD has gone up. This recent study in the Annual Review of Clinical Psychology suggested that there may be artifactual things that are going into what we may be perceiving as an ADHD epidemic. One of them may be the emphasis by drug companies for younger children to be using psychoactive medications, and a concern from individuals that there needs to be some form of a DSM diagnosis in order for children to get services in school. In some cases that may be true, but in many cases that the DSM diagnosis isn't necessarily needed in order to get special education services, but there certainly is that perception. Next. So one very important thing to consider is the age of the child. And I put this slide up here because this is a study that was done a couple of years ago in the U.S., but this same study has been replicated recently in Canada with a completely different cohort. What it suggests is that the rates of diagnosis among young children with ADHD and the rates of medication usage differ depending on your birth month. So on the left part of the slide, these are states in which the cutoff for kindergarten entrance was September 1st. And what you can see is that the month with the highest rate of ADHD diagnosis and medication use was August. In other words, the children who were youngest for grade. On the right slide, you see in states in which the cutoff for kindergarten entrance was either December 1st or 2nd. And you'll see that that the highest rates of ADHD diagnosis and medication use were among children born in November. Again, these are the youngest children in the grade. And I think it's important to note that one of the ways that we make a diagnosis of ADHD is by looking at children's behavior in comparison to other children around them. And when we ask teachers to give information about a child's behavior, the teacher typically compares a child's behavior to other children in the classroom. So I think it's important to recognize that some of these ratings and some of the decisions about whether or not a behavior is atypical or abnormal may simply be because the child's young for grade. Now, this issue is even exacerbated more if the child in question is a boy. This is because it's pretty well documented that boys and girls develop behaviorally, cognitively, and physically at a different rate than girls do, such that by entrance into kindergarten, girls are about a year ahead of boys in terms of their physical development, their motor development, their social emotional development, their language development, and their overall cognitive development. And so if you are a young for class boy in kindergarten or first grade, then you have two strikes against you in terms of being compared against other children in the class. And so I think that's an important thing to think about in who we are considering to have atypical or abnormal behaviors. Next. The other thing that's a concern, especially among young children, is that inattention, high activity level, the things that we see are part of the picture of ADHD. These are very common behaviors in typically developing children. By age 4, as many as 40% of children are identified by preschool teachers or by care providers as having concerns with attention. Not all of them go on to have ADHD. One thing we have found in the literature, though, is that the children who have quite severe signs of attention and hyperactivity in the preschool years that are persistent over time and across settings, very often these symptoms do persist and they do go on to be diagnosed as having ADHD. So I think one of the things that we think about in whether or not this is typical behavior or whether or not that the child is really having problems that will go on to be diagnosed with ADHD is how severe they are, how persistent they are, and whether or not they seem to be in conjunction with situational factors that tend to ebb and flow. Next slide. The issue, though, is that we certainly have identified that children that have ADHD have a much more difficult time throughout school, both in terms of social adjustment and their academic learning. There's twice the rate of school dropout among children with ADHD. There's greater retention and greater absenteeism. Some of that absenteeism has to do with healthcare concerns because children with ADHD get into accidents a little bit more and they have injuries more often than children without ADHD. What we do find among people with ADHD is that in general their psychosocial outcomes tend to be not as good, especially individuals who don't get comprehensive treatment. Those who do get comprehensive treatment tend to fare better, but among the individuals with ADHD who don't, they tend to fare more poorly. So I think it's, we've decided that it's, and observed that it's important to try to understand how this developmental disorder starts, how it plays out, and how we might think about identifying it earlier to really try to minimize these concerning outcomes among those with ADHD. Next slide. So our research team here is involved in a number of studies trying to identify the behaviors and the brain-related functions that really are associated with the onset of ADHD early in life. So we've been fortunate enough to be funded by the NIH to do a longitudinal study of preschool children who present with signs of ADHD. Now what we do is that we bring children into the study who either are typically developing or are children who are identified as looking like they have signs of ADHD when they are 4 years old. And these signs would be that these are hyperactive children, they're very inattentive, and that these symptoms are fairly persistent over time. And what we do is we bring them into the study and we assess them very carefully when they are 4 years old, and we also do brain imaging with them. And we take an MRI scan of their brain, and then we follow them for 3 years. And what we are looking for is changes in the way the brain develops early on that are associated with the behaviors we see that are fundamental to ADHD, and how these behaviors differ and how the brains differ than those in typically developing children. The interesting thing that we were able to find with this type of a study is that we were able to follow children to see what happens in the brain among children who look like they have ADHD and then ultimately grow into having that disorder by the time they hit school. But we're also able to see what happens in the brain among children who start off looking like they have ADHD, but then they, for all practical purposes, grow out of it by the time they hit school age. And we're able to see what's associated in the brain with that growing out of it. And we're in the process of doing this study right now, and hopefully in 2 to 3 years we'll be able to answer that question much more directly. We do have some preliminary data looking at early brain imaging studies of children with ADHD. Next slide, please. And this is what I believe is one of the only brain imaging studies of preschool children, ages 4 and 5, that has used neuroimaging to study the brains of children with ADHD. It's very difficult to get hyperactive 4-year-olds to lie still in an MRI scanner. So, and we don't do any sedation as part of this. We have behavioral training and desensitization that allows them to get comfortable with the scanner before we put them in, and oftentimes they fall asleep during the scan, and that helps us get good pictures. But what we have been able to identify, and that we published last year, is that even by age 4, there's a region of the brain, the caudate nucleus, which is in the subcortical parts of the brain, that is reduced already by the age of 4 in these children who look like they have ADHD. Moreover, that this reduction in this part of the brain, which is really very important in controlling cognitive control and motor control, this reduction in that part of the brain is associated with the severity of ADHD symptoms in these children. So that it looks like even by early age, there are changes in the brain that are really driving some of these behaviors that we see. Next slide. So the question I get asked all the time is, well, how do I know as a teacher, as a parent, as a clinician, whether or not this behavior that we're seeing in preschoolers is really an early sign of ADHD, or whether or not this is just common typical behavior? Inattention itself, as I said before, is very common among preschoolers. So I've identified, and my colleagues and I have put together a number of signs that if you see these things, you might start to think that this may be more ADHD than typical behavior. Next slide. So the first is that the child really dislikes or avoids activities that require paying attention for even a minute or two. And this could be something that in most kids would be very pleasurable, playing with a toy, listening to a story, watching something on the TV. If they really have difficulty staying with that activity for more than a minute or two, and that's pretty consistent, that could be a sign. Something similar, number 2, is that the child loses interest and after something that is even interesting to the child, and then wants to move on to something else. So that it's really difficult to sustain activity, especially in play. The third thing you might see is that a child is louder and makes a lot more noise than other children the same age. Now when you see that, certainly you would want to ask if that happens all of the time. And if it happens most of the time, and you've checked to make sure that the child doesn't have hearing loss, because certainly if the child has hearing loss, that may contribute to it. But if not, that being louder and more excitable may be a sign of leaning more towards ADHD. Next slide. So the other thing that we see in preschoolers is a lot more climbing and getting into dangerous activities than you should. Oftentimes, the children have more ambition and more inquisitiveness and less judgment and care about what might be a dangerous situation. So they often climb up on things. They may climb onto windows, onto cabinets when they're not supposed to, and even after they're told that they're not supposed to. One of the interesting findings is that in most children with ADHD, if you look carefully enough, there is also some motor coordination development problem as well. One of the signs that we have identified and has been published in the literature for years is that the inability to hop on one foot by age 4. Now, this is not hopping a bunch of times. This is just hopping one time on one foot by age 4. The inability to do that is a pretty good predictor of who goes on to have problems with inattention and hyperactivity. The main reason for that is that the brain systems that support motor development and the ones that support attention and executive function control, which are disrupted in ADHD, those systems really develop in parallel, so it's not surprising to see difficulties with them go hand in hand. The next one is that young children with ADHD, young children may be at risk for ADHD if they just can't sit in a place without wiggling and sitting still. Most preschoolers, 3-4 years old, don't mind sitting on someone's lap or sitting with someone on a sofa, for a period of time if they're doing something enjoyable. But children who are at risk for ADHD just simply won't sit in a chair for very long, won't want to kick around a lot, want to be moving around, and it's almost aversive for them to be seated in a seat. And some even find in a high chair as a younger children for more than just a few minutes. Next slide. As I mentioned before, one of the things that we see a lot is the children may have gotten into dangerous situations. When in our children that we evaluate who have ADHD in the preschool years, very often you find that they have run into things and have gotten stitches in their arms or in their heads because they've gotten into dangerous situations. The next thing is that they warm up often too quickly with strangers. In other words, they don't seem to have the routine kinds of persistent stranger anxiety that you see in young children, and that they'll go right up to strangers and without any fear, even after they've been warned. In school and in the playground, they are more often aggressive. They tend towards aggression more quickly than other children. And what we often see among the children who get referred to our care and to our study is that they are either in risk of or have been thrown out of their preschool for having aggression. Usually this aggression, though, isn't unprovoked. It's usually in the context of frustration. And what we see is that the child goes from being a little bit frustrated to very frustrated and aggressive very quickly. So it's not that the child is aggressive per se. That it's more of a poor frustration tolerance. And then, as I mentioned before, often the children with ADHD in the younger years often get stitches and get injured for moving more quickly than they're supposed to. Next slide. So in conclusion, I would say that if parents see a lot of these symptoms or have concerns about it, this is the time when they should really note these and go see the pediatrician or other developmental expert. The reason is that the American Academy of Pediatrics has now published guidelines that make it much more clear for pediatricians about how to think about ADHD in the preschool years and how to even think about treating it. It used to be that pediatricians were very reluctant to do this, and now the reluctance has subsided quite a bit. That's not to say that all children with hyperactivity in the preschool years should get stimulant medicine. That's not what I'm suggesting at all. In fact, I think there are a lot of other kinds of supports that can be put into place early on that when done, can possibly minimize the need for other kinds of pharmacological treatment later on. But these kinds of things can be effectively identified in the preschool years. So I'll leave it at that, and I guess go on for questions.
Thank you, Dr. Mahone. To the audience, we already have a number of very good questions, but you are welcome to submit any questions that you may have now in the questions box as indicated by this slide. And Dr. Mahone, I will I will actually group questions in order to get to as many as possible. So the first, and some of the questions you have touched on in your presentation, but you may want to elaborate. So the first group of questions will deal with diagnoses. And the very first question is, what type of professional is most qualified to evaluate or diagnose a young child for ADHD? And just related to that, there is also a question about diagnosing ADHD or autism in young children as well. I don't know if you'd like to speak to that as well.
Okay. I'll address the first one about what kind of professional is really best to do the diagnosing. I think it's important to recognize that ADHD is really it's a behavioral diagnosis, first of all. In other words, we make the diagnosis on the basis of observing behaviors over different situations and over time. There's no lab test, no single MRI in an individual child or an EEG will make this diagnosis. So because it's a disorder that is made on the basis of behaviors, it's really made after ruling out a number of other things. So it's very important that in the course of making a diagnosis, the child's physical health be carefully evaluated. And that can be done by the pediatrician or family practitioner or other medical professional that can do a good, thorough physical examination to make sure there are no physical problems that could be leading to the behaviors that you see. On top of that, we also need to rule out other things that might mimic the behaviors of ADHD. And those things might be situational anxiety or stress. It may be a language processing disorder. They may be an intellectual disability. Might be hearing loss. There may be some other kinds of cognitive or developmental problems such as depression that may mimic those problems in young children. That's where a psychologist or a psychiatrist is often very helpful as part of the team in working up the diagnosis. So I think there's really two parts. One that is the physical part of the workup, and the second that is really the careful looking at the rule-outs, and then the final is actually ruling in the disorder, because there are a number of components of the disorder that have to be met in order to make the diagnosis, and those include not only the symptoms, but the fact that the symptoms have caused impairment in the child's life, and that they persist in different settings and over time. So psychologists, psychiatrists, pediatricians, developmental pediatricians, child neurologists are all important players in this process. The second question was about ADHD and autism, and I'm not sure the specific question, but one of the things that comes up very often is whether or not these behaviors that you are seeing that are atypical in a preschool child are more consistent with an autism spectrum disorder, or are they more consistent with ADHD? And it's been my experience that very often when children get referred for an autism assessment and they are found not to have autism, what they are found to have instead is something that's similar to ADHD, if not ADHD. So I think that the professionals who do work with young children should be well versed in both autism spectrum disorders and ADHD, because there is some overlap in the symptoms, especially in the younger children. That being said, there's parts of each of the disorders that are very different from one another. But I think the professionals that should be that are evaluating for these disorders should be very well versed in both, and to be able to make that differential diagnosis.
Thank you very much. I have also a couple questions that are related to symptoms, and I'll give them to you just as they're written, and you can decide what will make sense of them and answer them as best as possible. One question is, are ADHD symptoms exacerbated by dietary additives, and Also, have you found that colic, insomnia, and or sleep disorders are indicative of an ADHD diagnosis in young children?
Okay, I'll take the first one first. So, are the symptoms of ADHD exacerbated by different additives in foods? There have been some recent studies to suggest that in some children there are an exacerbation of symptoms on the basis of certain additives in food and certain foods themselves, and that doesn't mean that those additives or the foods themselves cause ADHD. It just means that in children who may be at risk for ADHD or those who actually have the disorder already, it may exacerbate some of the symptoms. It also may exacerbate some of those symptoms in children who don't have ADHD. So, for example, there may be a child whose behavior is very typical, and then if that child eats some type of a food additive, then that child's behavior shortly after eating that food may change, and the child's behavior is not like that otherwise. That's not ADHD. That's a sensitivity to a food additive that may be applicable in some children, but it's certainly by no means the case for most or all of the children with ADHD, and there's a lot of variability there, but certainly in some children. The second question, again, was...
the second question is related to colic, insomnia, and sleep disorders. Are they indicative of ADHD diagnosis in young children?
Well, colic, first of all, is pretty common, and there have been some earlier studies to suggest that in some of the studies there has been an increased incidence of or an increased relationship among incidence of colic and later onset of ADHD, but that hasn't been consistently reported in all the studies. The second question about sleep problems, though, is really a good one, because sleep problems are common in children with all kinds of neurodevelopmental disorders, including ADHD. Now, there's a couple of different kinds of sleep problems. One is more of a physical problem in which you really have difficulties with the sleep-wake cycle, such that you really aren't getting into what we call slow-wave sleep at night, and so you're not having good consolidated sleep. And for anyone, whether you have ADHD or not, if you don't get a good night's sleep, you're not going to function very well the next day. You're going to be more inattentive and more distractible. So for anyone who has a sleep disorder, it's going to make you more vulnerable to attention problems. The opposite of that, though, is that there is a high incidence and a high rate of behavioral sleep problems among children with ADHD. And what that means is that they are just very, very restless. They have trouble getting settled down for sleep, that they move around a lot more during the night, and as a result of that, they also don't get a good night's sleep. The result of both of these things, though, is the fact that you don't get a good consolidated night of sleep, and that affects your cognitive development, it affects your attention, and it affects your availability, your availability for learning in school. So yes, there's a significant association with sleep problems and ADHD, and whenever one is assessing for ADHD, the professional should also ask about and assess for sleep problems.
Okay, thank you. We have another question that is related to the actual diagnosis. Is the current DSM-4 criteria reliable for diagnosing ADHD in preschool children?
There are definitely concerns with the current DSM-4 that are actually going to be addressed when the DSM-5 comes out next year. One of the problems is that ADHD is a developmental disorder, and as a developmental disorder, it looks different depending on what age you are. So, for example, the disorder of ADHD looks different among preschoolers than it does among school-age children, than it does among high schoolers and adults. It looks very different. The primary symptoms are different. The severity of symptoms tends to be different, and I think that wasn't captured very well in the DSM-4 because it had a set of criteria that was invariant across time. So the diagnosis was the same for for an 18-year-old as it was for a 3-year-old, and that really doesn't make a lot of sense because they're very, very different individuals. I think that the DSM-5 will help that. I don't know if it will correct all of those problems, but it certainly identifies that that there are different kinds of patterns that one sees at different ages with ADHD. In young children with ADHD, especially preschoolers, you're much more likely to see the hyperactive conditions and much less likely to see a primary presentation of inattentive symptoms. Conversely, in an older child, you're much more likely to see inattention and disorganization be the primary symptom, and a lot less of the hyperactivity. And so, knowing that, we can take a closer look at what the phenotypes of those disorders look like at different ages. But it doesn't mean it's a different disorder. It just means that it looks different at different ages. So, the DSM doesn't fully account for that, and I think it's up to the clinicians to be able to have a very good sense of what is typical behavior and what's atypical behavior for a 3-year-old or a 4-year-old to be able to try to make this diagnosis in the preschool years.
Thank you. And can you recommend some things that a parent or other adult would look for in a clinician who, in terms of qualifications and experience, that would help them get the most accurate diagnosis?
Well, I don't necessarily know that it's a type of clinician, for example. So I think that even among my psychologist colleagues, there are those of us who really specialize in and work with and have a lot of experience in working with young and preschool children, and those who don't. So among psychologists, you would want someone who has, as part of his or her regular practice, that sees a lot of preschoolers, that has a good working knowledge of what is typical behavior among preschoolers. And you don't want to work with someone who really doesn't see preschoolers very often, or mostly works with adolescents, for example, and would be less comfortable working with a preschooler. The same thing goes for child neurologists, psychiatrists, and even developmental pediatricians. Probably less so among the developmental pediatricians, because most of those folks work with very young children and are very comfortable with working with young children. But even among neurologists and psychiatrists, some are much more comfortable working with very young children in preschool years than others, especially psychiatrists. So a lot of the child and adolescent psychiatrists don't specialize in working with preschoolers, and there are a few that do, so you would just need to ask.
Okay, thank you. Switching gears to treatment now, the first question is, what would you consider to be a comprehensive treatment plan? And I guess along with that does that mean that medication is not enough as far as treatment is concerned?
Well, there are a lot of steps to the question. So the first part of any of this is to get an appropriate and comprehensive assessment. And as I mentioned earlier, one of the main points about ADHD is that it rarely exists in isolation. So a comprehensive assessment first, takes into account all of the conditions that a child might have, and if it is ADHD and a diagnosis of ADHD is ruled in on the basis of symptoms and on the basis of ruling out other conditions, the next question is, well, is there something else? So if it's ADHD plus the something else, then the treatment would need to account for the ADHD plus the something else. And if it's just the ADHD alone, then the treatment should never really be just one thing in isolation. So the comprehensive treatments for ADHD include thinking about behavior management, working with the parents on different kinds of behavioral strategies, and working with the daycare centers and the preschools for helping to understand the different kinds of needs that a child with ADHD might have, in terms of the need to be able to move around more, the need to be able to have much more physical activity, the difficulties with sitting still for story time. So working with the daycare or the preschool, working with the parents and the child with behavior management, and working with any coexisting conditions. If there's a language disorder, if there's a learning disability, working to treat that. If there's a motor skill development problem, working to treat that. Then finally, after all of those things are in place and are considered, then it's important to think about whether or not medication is part of the treatment. And it isn't always, but in some children with very severe hyperactivity and those who get into dangerous behaviors and those who are only responding so well to all of those other interventions, for those children, then yeah, I do think that medication is part of the picture and should be done in conjunction with those other therapies.
Thank you very much. And there are a number of other questions. Again, some of them you may have touched on, but I will read them. One question relates to discipline, and it is, what are the best forms of discipline to use with a preschool child with ADHD?
I think that discipline, I think what the question is what are the best forms of behavior management with children with ADHD, because discipline is really teaching, and the best way to teach is through reinforcing appropriate behaviors. And what we have learned from behavioral psychologists over the last 50 years is that the most effective forms of behavior management involve reinforcing appropriate behavior and not reinforcing inappropriate behavior. They do not involve, primarily punishment. And so behavior management plans that are primarily leading with punishment, they tend not to work. And I'm not talking about spanking or hitting. I'm talking about any kind of punishment, whether that's just yelling or taking away a privilege or giving a timeout. That when discipline or behavior management programs are primarily focusing on the punishment, then they're really not going to be as effective as those that focus on reinforcement of appropriate behaviors. I guess one of the easiest ways to think about it is if you have a young child that has behaviors, then you have several kinds of behaviors that are present in the child. Ones that are good behaviors and ones that the behaviors that you like and you want to reinforce. The second kind are really, really oppositional or defiant or very, very dangerous behaviors. And these are ones that need to be stopped and so that the child doesn't hurt himself or herself. And then the third kind of behavior that is really very, very common are what I would call annoying behaviors. These aren't flat-out defiant or bad behaviors. They're just annoying. And so I think that the positive behaviors tend to be ones that you want to reinforce, and you want to spend a lot of very specific effort reinforcing all of the times when the child's doing what he or she is supposed to do, and you pay a lot of attention to the child then. That you need to intervene immediately and take the child out of a situation when the child is doing something dangerous or defiant. And in doing so, you should do that as quickly as possible and with as little speaking and talking as possible, because you don't want to engage in an argument or a discussion when a child is having defiant behavior. And then the third group are the annoying behaviors. And I know it's difficult, but I think one of the traps that parents tend to fall into is that they spend way too much time paying attention to those annoying behaviors and inadvertently reinforcing them. So the annoying behaviors are the ones that need to be differentially ignored. And that if you think about your attention as being almost like a light switch, and that when the child is doing something positive, you turn on the light switch and focus it right on the child. And when the child is doing something annoying, you take your attention away from the child immediately and only return your attention when the child starts to do something good again. Now, this is never going to work in just one trial, but over the course of time, training yourself not to attend to those annoying behaviors doesn't fall into the trap of inadvertently reinforcing it. So that's a general framework, and that the behavioral specialists who work with young children tend to follow that framework.
Okay, thank you. Those are some excellent suggestions. Would you happen to have any reading material or other resources that parents can refer to?
There are lots of them. There are lots of them. I know Russ Barkley has written a number of books for young children about defiant children. There's a book I've used frequently called SOS Help for Parents. It's written by a psychologist named Lynn Clark. I like that one a lot because it's really very, very nuts and bolts, very simple to use, and it breaks down a lot of those behaviors like I just did. But one of the things is it helps parents with our traps they get pulled into, and how they end up doing things inadvertently that end up contributing to the bad behavior rather than trying to help it, and they do that without thinking about it sometimes.
And that title again was SOS
Help for Parents.
Okay, by Lynn
Clark.
Okay, thank you. And to the audience, we also have a list of staff favorites on the National Resource Center's website, Books for Parents, so you can go there to www.help4 and adhd.org and look for our staff favorites. The next question relates to medication, and you've touched on medication before, but there's a specific question about what age is it safe or appropriate to start medication treatment?
That's a very good question. The American Academy of Pediatrics has just published guidelines about what to do and how to think about using medications in preschool age children. I think if you consider all of the caveats that I put out earlier, and you are working with a provider, a psychiatrist or a developmental pediatrician, or a pediatrician who's very familiar with working with medications in very young children, then when there is a need to do it, and it can be appropriate to do that at age 3 or 4, but it's done very carefully and very sparingly, and I think it's only used at that age when the other options have been exhausted and when the child is so hyperactive that other interventions haven't worked and that the child gets into very, very dangerous situations. I see it used in children this age when this is a child who you can't be stopped from running out into the street or is crawling out of windows and is falling a lot and getting into very dangerous situations. The medication isn't used to treat oppositional behavior. That's more appropriate to have behavior management therapies. But it's only when the impulsiveness and the hyperactivity lead to very dangerous situations and that other treatments have failed that it would be considered for young children like that. Now, that being said, there have been controlled studies of the use of stimulant medication in very young children, and it's much more challenging to try to introduce stimulant medicine to younger children like that. The effects, while they are there and they do show positive effects for children in this age range, there do tend to be more side effects, especially early on with the younger children, compared to when you use medication for older children.
Thank you. I'm going to switch gears again and go to a number of questions about ADHD in young children in the school environment. And the first question, which I think is a very good one, is should a young child with ADHD be held back a year before they start school, or you mentioned earlier the children that are born later in the year. Do you have any thoughts about parents holding a child back a year or so before starting school?
That is a good question, and the quick answer is that it depends. But I think you bring up a very good point. What is the main reason that the child is being considered to be held back? And if the child is young for grade, if the child would be one of the younger children in the grade, if the child is a boy, and that the child is having behaviors and difficulties with social development that are a function of the ADHD, then it probably is a good idea to delay going into school a year. And I think it's probably better to delay entry to school than to find out about it later on and have to be held back once you're already in school. That often doesn't seem to work well once you're in school. So I think it's really thought of as being preferable to hold back a year if the child is really having social difficulties or behavioral difficulties and trouble controlling one's behavior, especially if the child would be one of the younger ones in the grade. The second question, though, would be, is the reason more a problem of a learning disability or difficulty learning that is not necessarily a specific problem of ADHD, because that might require a different kind of an intervention. It might require that the child might need to be assessed for some specialized educational services, especially with regard to language development or reading development, and that with those specialized education services that the child could progress into the regular grade at the regular time. So I think it really does depend on why the child is being considered, and if it was purely a matter of kind of social development and behavioral control and being able to follow rules, that extra year, especially if they're a younger one in the grade, does tend to help.
And you bring up a very good point related to educational accommodations or special education services for children who are of preschool age. How would parents go about initiating that? Are preschool children also can they also have access to special education services?
Yes, anyone. Any child of any age can have access to specialized developmental or educational services. It's done through different systems. So from birth to 3, it's done through the infants and toddlers system, and it's done. The services are provided through local, either county or state agencies that provide that service directly to the family. Once the child turns 3 years old, those services are assumed by the local public school systems, and so any child 3 and above can be assessed for a disability, a qualifying disability, under the Individuals with Disabilities Education Act that would afford them the opportunity to have specialized education services in the school. Now, for ADHD, first of all, for young children, often that takes the form of what we call a developmental delay, and that would be the condition that would be diagnosed to afford the child special education services in the preschool years. It doesn't have to be under developmental delay. It could be under ADHD. It could be under a language disorder if that was the condition. But regardless of how they get qualified for special education services, the types of interventions that would be provided are really based on the child's identified needs, regardless of the diagnosis. That being said, once you are diagnosed with ADHD, and if that's the only condition you are diagnosed with, then it is possible to get an IEP or an individualized education plan for special education services under what's called the other health impaired criterion. It isn't. It doesn't have to be given though, but it is possible to get special education services for ADHD under the other health impaired criterion if the child's academic development and social development in school are adversely affected by the disorder. Then they can get services. Another avenue in which individuals can get accommodations is through what we call a 504 plan, and that the 504 plan recognizes that individuals with disabilities should have access to all public offerings, including school, and those accommodations through a 504 plan are made through the Americans with Disabilities Act. So it's a different public law that gives you different things. So the 504 plan is not special education, whereas an IEP is special education.
Thank you very much. We have time for about 2 more questions, and the next one is from a parent who wants to know what school environment may be best for a child that's been diagnosed with ADHD, and the question is public or private, Montessori or such. So.
I would be hard pressed to say that that one of the 3 of those would be better than the others, and there are real positive things about all 3 settings. I think one of the real important issues is to work with the child's preschool teacher to make sure that the teacher is knowledgeable about the needs of a child with ADHD, knowledgeable about this individual child's needs, and flexible enough to be able to work with and accommodate the kinds of things that may be unique needs of a child with ADHD. For example, a teacher who would tend to be more inclined to have a lot of sit down at the desk work might not be a good match. And so you want a lot of being able to be flexible among the teachers, and that can occur anywhere. Now, there's a lot of good things about the Montessori setting, including a lot of organized movement and a lot of integrating of moving around and changing activities that is somewhat more directed by the child, and children with ADHD tend to like that. And I think in a good Montessori setting, that an otherwise typically developing child with ADHD can do well there. Sometimes the transition back to a more structured and typical classroom from a Montessori setting among children with ADHD tends to be a challenge, though. Across the board, though, children with ADHD, even especially young children, tend to do a little better in smaller groups. So regardless of the setting, I think opportunities for working with smaller group settings and having a smaller teacher-to-student ratio, regardless of where it is, that seems to be helpful for children.
Thank you. And we have one last question. Actually, you may be able to get to another one, but this question is it typical for children with ADHD to display odd social behaviors? And there isn't any elaboration on what odd social behaviors is, but if you...
Well, I guess it would depend on what the definition or what the example of odd would be. But generally speaking, yes. I mean, children with ADHD can do a lot of things that people might consider odd that in large part, especially if they are young children, it's because they're impulsive. And so children, young children with ADHD may say out loud a lot of things that are on their mind, whereas other children may be more inclined to think it but not say it. So sometimes you get more of a stream of consciousness among children with ADHD. Sometimes they are not aware of some of the things that are coming out of their mouth. So they may be more inclined to make animal noises, for example, or to mimic something that someone else has said out of context and not think about it so much. And those may be considered odd. Socially, children with ADHD, especially young ones, can, in some situations, be more bossy. They can have more trouble with frustration tolerance, which gives them some difficulties with other children their age who may not understand them as well. And so they may be considered unusual. So, sure, there's lots of behaviors that would be considered by some to be odd or unusual that could be part of the ADHD picture.
Dr. Mahone, thank you very much. That's actually all the questions that we have time for today. So I would like to thank you again for taking the time to be with us today and for providing some terrific answers to some very good questions from our audience. To our audience...
So thank you all, and thank you to Chad and the National Research Center on ADHD for inviting me to participate.
Thank you, and we would love to have you back at some point in the future if your schedule permits and you're willing to do so. And I'm sorry, go ahead.
Sure thing.
Okay, and to our audience, just briefly, if you have any additional questions that were not addressed today, you can contact the National Resource Center at 800-233-4050 to speak with one of our health information specialists. A recording of this webinar will be available at the NRC's website within a week or two at www.help, the number 4, and then adhd.org. You can see that URL address on the slide. Thank you again for your participation, and please go to our website to see the next the schedule of webinars upcoming. And finally, one last point, if you would be kind enough to complete the survey when you receive an email from us asking you for your feedback on this webinar, we would really, really appreciate that. Thank you again, and enjoy the rest of your day.